on successful healthcare models. The way I'd like to go through it is to essentially give a very brief overview in terms of how different aspects and segments of healthcare influence the operations and result in success and where models can be either failures or successful, and what would probably go into it. We have today a very distinguished panel of speakers. Dr. Harish Pillai, who's the CEO, Astor DM Healthcare. Mr. Sudarshan Jain, MD, Healthcare Solutions, Abbott India. Dr. GSK Velu, MD, Trivitron Group of Companies. And Mr. Sadanand Reddy, MD, Gold Star Healthcare. And these gentlemen will be speaking in that order. After my introduction, I will ask each of them to come forward and present. We would like to take the questions at the end, except in the case of Mr. Sudarshan Jain, since he has certain prior commitments, he's got to leave a little early. So he would like to take the questions after he finishes his presentation. Before we go ahead, let me introduce to you this distinguished panel. Dr. Harish Pillai, who is the CEO of Astor MedCity. This is an iconic homegrown integrated medical city of international standard. He's got wide experience and worked not only in India, but in the UAE and Egypt. His expertise lies in commissioning both greenfield hospitals as well as in leading strategic restructuring of sick projects. And in his distinguished career, he's also been awarded several recognitions and awards. And he has been the recipient of Dr. Pratap C. Reddy Award for Excellence at Apollo Institute of Hospital Administration in Hyderabad, and was also the best student at Frankfurt School. Dr. Harish Pillai. Just 1 minute. Let me finish the... Sorry. The second speaker is from the pharma sector, Mr. Sudarshan Jain, who's the MD, Healthcare Solutions, Abbott India. He was also the executive director of the same organization. As Director, Healthcare Solutions Business, he worked with Piramal Healthcare till 2008 December, and was responsible for the domestic branded formulation business called Healthcare Solutions. And prior to that, he was the Group Product Manager of Johnson & Johnson and Deputy Manager Sales Promotion and Training at Lupin Laboratories. I welcome you. The third speaker is going to join us shortly. This is Dr. GSK Velu, Pilani in Pharmacy and a PhD in Pharmacology from IBM. Managing Director of Trivitron Group of Companies. He's also the founder and Vice Chairman of Metropolis Health Services. He started Trivitron in 1997 and tied up with several world leaders in medical technology to cater to over 20 medical specialties across India. He's the only person in the healthcare industry to receive the ITM University Awards for Corporate Excellence in the year 2006. I welcome him. He will be joining us shortly. And the fourth speaker is from the IT sector, Mr. Sadanand Reddy. He's the MD, Gold Star Healthcare Private Limited. He's previously held many important positions in Apollo Hospitals, including as General Manager, Operations and General Manager, Materials and Operations. He was General Manager for Apollo Hospitals, and he has been the President in the Prastha Telugu Association. He has various publications in several magazines, including eHealth and Express Healthcare and others. I welcome all the speakers today. Four categories, and I think Dr. Rajiv this morning very, very eloquently expressed that. The first three are successful healthcare models where there is availability, there's accessibility and affordability. And there's a fourth A, which I called efficiency, with an A, with the A being silent. I think availability, accessibility, affordability, and efficiency are the four pillars under which we can have several examples of how healthcare has been successfully delivered and how stakeholders in the healthcare industry. Let me quickly start off in the case of, in the area of healthcare delivery. It's really an issue of availability. We talked in terms of models of delivery, which would be multi-speciality, single speciality, secondary care, primary care, and we've seen quite a few successful models there. But there are also new concepts coming up, concepts of daycare, day surgery, home care, where you're talking in terms of extending the reach, accessibility, new concepts which make it far more affordable, far more convenient. We have integrated models where the entire primary, secondary healthcare systems are integrated. You have hubs and spokes. You have urban, semi-urban, semi-rural, rural models. And you also have now public-private partnerships where there are very successful models of how these have worked, where the government and the private sector have come together. The next three, where we have our speakers, along with Dr. Pillai, cover equipment and devices, pharma, and IT. If you look at equipment and devices, here again we're talking in terms of affordable care and efficient care. You talk of project costs, and unfortunately, costs don't change significantly if you go from different tier level cities, where you have tier 1, tier 2, tier 3. The cost of equipment across this remains the same, and therefore impacts significantly the margins with these projects. So how do equipment manufacturers address this more efficiently, make it far more affordable, so that the cost of equipment in the total project cost becomes far more manageable? Dr. Rajiv talked very, very well and clearly and lucidly in innovation for better care, better clinical outcomes, innovation which makes healthcare far more affordable. And again, there are fairly successful models here where quite a few of the equipment manufacturers, both international as well as indigenous manufacturers, are looking very closely in terms of addressing both affordability as well as. Third is in terms of pharmaceutical companies. Here, there are quite a few challenges in terms of the fact that the government today is looking very closely towards affordable care. How do we look at bringing down the price? Government coming with price controls. Government talking in terms of generic drugs. We also have today government-sponsored insurance schemes where the price points are fixed by the government, and it is for healthcare delivery entities to look at how they can manage costs far more efficiently. So now it's not just a question of the revenues, we are talking in terms of managing the expense lines, especially with respect to consumables, whether they be general consumables or pharmacy consumables, in a much more efficient way. And finally, you have IT and technology. And I think this is really going to be a game changer. Again, some of the examples you have been shown earlier, but we talk in terms of mobile and Wi-Fi technology, we talk in terms of handheld devices, we're talking in terms of telephony, and a lot of this is already in the process of being developed and used. We in our own hospitals are talking of this to make things far more accessible and far more efficient. We talk of the web, where we have healthcare applications, healthcare portals. We talk of teletechnology, which is telemedicine, radiology, EICUs, where you're trying to extend the reach to address the challenges of both expertise as well as availability. And finally, we're talking in terms of IT, use of HRS systems, use of analytics, use of processes, and several other ways in which to make things far more efficient. And of course, universal coverage requiring a better e-payment mechanism. So broadly, if you look at all of this, you talk in terms of models in delivery, you talk in terms of models in pharma, you talk in terms of models in equipment and devices, and you talk in terms of IT, which each of the speakers will present. But underlying all this, 2 minutes, but I'll finish in 1 minute. Underlying all this, because I think that is really what underpins all of this. You need, and financial success comes from how successful these deliveries, these models, these innovations have been with respect to the main customer of this sector, who's the patient. And today, you see that happening. You see a lot of a private equity willing to look at investment in healthcare, which was not there 5, 6 years ago. And there's a significant amount of interest in terms of how some of these successes have ready takers to fund it, to finance it, and therefore revenue and EBITDA becomes critical because the multiples of that really help in generating the funds to grow this industry far, far quicker and far wider, and therefore make healthcare available, accessible, affordable, and efficient. With those few words, let me now request the first speaker, Dr. Harish Pillai, to present to you his successful healthcare model in the area of delivery. Dr. Harish Pillai.
While the technical things are being fixed, I'll just, for the sake of time, the journey started quite some time back in the year 1987, where there was this, I would say, relatively young physician with starry eyes in his eyes. He was already trained to be a respiratory physician, and I can tell you from personal experience because I too am a second-generation expat because I grew up in Dubai. Been there from 70s to 80s. So those days when we were young kids, if you fall sick, then you have access to public health systems. You don't have really private hospitals there. And you have to pray. I mean, as an Indian, one prays that the doctor you're going to see in the public health system is of your country of origin for natural reasons. You have cultural affinity and you have a conscious idea of the quality of healthcare back home, so you will feel more comfortable. So that was predominantly in 70s and 80s. So when the chairman of this company, Dr. Mopen, in those days was just a young physician, he decided to go to Dubai for a social cause. A lot of people, well-wishers, told him that, Doc, we badly need to have a good doctor in the private setup out here. So in 1987, the man who crossed the shores for something else landed up setting up a first clinic out in Dubai. It's an Indian company which is interesting as you can see going forward. Now, this country, since it's almost like home for me, I can just tell you that all macro indicators were quite bad. It's just a desert country. And if, like Dr. Rajiv was talking about, if you want to understand the molecule of a vision, this is a good country to look at because there is nothing there. Dubai does not even have oil. You can say Abu Dhabi floats in oil for the next 100 years, but Dubai's oil reserves got exhausted in 10 years' time. Just sand. So to make a city, a huge global city just out of sand takes power of vision. So that's what the city came about. But in the days when I was growing up in Dubai in 1970s, it was much more humble, much more smaller, predominantly an Asian population. So you can see from the health indicators that there was a real need for good quality healthcare in that country. Same thing in terms of population. It's remarkable that the number of locals, Emiratis as they're called, are so few in number. And you will find probably every country on the planet represented in UAE except for the state of Israel due to political reasons. Almost everyone in the planet is out there. Indians as a huge expat community, we are the backbone of the economy, right from construction sector to the big CEOs of Dubai. It's all from the large Indian diaspora, what is there. So this population also needs to have access for healthcare. When we look at demographic changes, naturally, if you ask me that the success story of the Gulf countries would not have been so if not for the proximity of South Asia, predominantly that India is so close by. You can really say that the success story of a country like UAE is because of the hard work, the sweat and tears of large expat population, predominantly from South Asia. So it's a very peculiar situation where you have a lot of males in the society, young working people who are you're not supposed to be falling sick when you work in an environment like UAE, but that's what the demographic profile shows. But over a course of time, the small UAE population would naturally get older and older. So that's what in 1987, when Dr. Mupin went to Dubai, he had to borrow money from friends, well-wishers, and family. He did not have first clinic. Just few days back, I asked him, Dr. Mupin, how was it in the old days? He said, I never saw a single patient. Because nobody knows me in Dubai, how will I get my patients? So those well-wishers who convinced him that, to set up a clinic, when they used to call him, he used to say that, I don't want any gifts, please give me a patient. So almost for 5 years from 1987, this was a single doctor practice in primary care. I mean, since he's a respiratory physician, I would also call it a secondary care, but just a clinic at the end of the day. So these were the real humble beginnings of Astor DM Healthcare as we go forward. So when you talk about visionary and growth, sometime in 90s, Dr. Mupin was feeling homesick. He said that this is enough. I thought I'll make some money and see some patients and do some social service. But he also had a heart in academics because he was a lecturer at the Calicut Medical College. He thought that he will go back into academics to his hometown and be part of the clinical faculty. Somehow, it was just destiny. I would say that he stood back and said that, no, I could probably do something more. So if you look at those milestones in 1987 to 2001, the group had just 5 units, predominantly into primary care. When you move on, there's a huge jump. 2002 to 2007, you had 49 units, so you had 22 clinics. You started the first set of hospitals. I do remember, because I had the good fortune of building Dubai's first acute care hospital in the private sector in the early 2000s. So as an acute care hospital director, you normally ask community-based doctors to come and admit your patients to your facility. So I met Dr. Mupin in the early 2000s to convince him to bring his patients to my hospital. And I could see that this man was a bit different. Or program for great success. In 2005, he built up his first secondary care hospital mainly for OBGYN and pediatrics. Now going on, 2008 to 2009, from 49 units, you made 72 units, and then again, exponential growth to 116 and 168. But there are some key milestones if you look at it. Sometime, like I said, the time when he thought he'll go back home, he was also thinking that he would get a lot of NRIs together, non-resident Indians, to invest together to create a good tertiary care hospital. This resulted in creating India's first NABH accredited multi-speciality hospital in Calicut called MIMS, the Malabar Institute of Medical Sciences, a genuine tertiary care hospital. So that was also because of Dr. Mupin's entrepreneurship and the visionary zeal which he had. The big game changer, if you ask me, was to talk about private equity funding. Even much before that, he could sense that a population in UAE, because it's of its cosmopolitan environment and multi-ethnicity, requires a different type of a hospital. And Dr. Mupin's units were predominantly perceived by the consumer base to be an Asian type of a healthcare entity. So what he thought was that I will create an international hospital much before the PE funds came in, and that project was called Medcare. If any of you go to UAE and go to a Medcare hospital, it's truly international in its design, in terms of composition of staff, and its clinical expertise. And then came, of course, the first PE funding from India Value Fund, and then everything changed dramatically. You had a vision document which talked about a roadmap for the year 2015, but this entity succeeded in achieving all the vision 2015 goals ahead of its time in 2012, in 2012. So now they have rolled out a map called 2025. So that's Dr. Mopin. Everyone starts with a dream. And most of you as students, you have access to literature, which gives you fantastic examples in healthcare. Personally, I think I'm quite lucky that I also got to work with Dr. Reddy, the so-called founder of corporate healthcare in India while I was with the Apollo hospitals. I got to work with a European healthcare leader called Dr. Bruman, who heads the second largest healthcare chain in Europe called the Asclepios chain. I got to work with, of course, Dr. Mopin. So these are, if you ask, there is a common factor which binds all of them together is that they're always restless. They do not sit back on past laurels. They are not comfortable with status quo. So this is something which you have to take home, because you never know. Many of you in this audience could be future entrepreneurs. You could be catalysts of change. So you got to believe in that extraordinary gift which all of us are born with. So again, as milestones in 2001, I told you that in the earlier days, Dr. Mopin was a single doctor practice. In 2001, he decided to bring in management teams together, and the first management company was created called Dr. Mopin's Healthcare Management Services, LLC. In 2007, because there were too many brands, I told you about those numbers, they were all called by different names. So there was so much of confusion. Nobody realized that all these different entities are actually under the same umbrella. So 2007, they called a market research firm. They talked about brand engagement and rebranding strategy, and that's how the brand Astor was. Astor is just a flower, and it embodies the principles of this group. So the vision of this company is basically a caring vision with a global mission. It's a very simple, easy to remember, because we, unlike the large corporate entities in India, we are predominantly located overseas, and now we hope to have a new saga in Indian healthcare. So that's the rebranding exercise from the earlier days. Today, the holding company is called Astor DM Healthcare, and henceforth, all our hospitals will be under the brand name Astor. We are also in Maharashtra, in the city of Pune. Our project is called Astor MediPoint. We have a unit in Kolhapur, which is Astor Aadhar. So that's the group structure, where you have the promoters, and then you have the two private equity partners, both India Value Fund and Olympus Capital, and then you have your different structures. In terms of revenue share currently, predominantly 52% of revenue come from the hospital vertical. You have 22% from clinics and 26% from pharmacies. But as per the vision document of 2025, this pie chart is going to change, where we are forecasting 65 to 70% of revenue coming from the hospital sector. In terms of regions, naturally, we are quite strong in the United Arab Emirates, where currently 68% of the revenue comes from there. We also are betting that a large chunk of future revenues would come from India operations. In terms of people, we are a 10,000 strong company looking at all nationalities. The two large segment of employees in the company are Indians, followed by staff from the Philippines. But we have Americans, we have a lot of European staff, we have, of course, employees from West Asia, from Jordan, from Egypt, from all these countries are represented in our 10,000 strong workforce. In terms of locations, we are right now in 175 locations, mainly across these geographies. We have 3 brands which we are promoting overseas, mainly called Access, Astor, and Medcare. Access is more into primary care. Astor is our flagship brand, which is into primary care, secondary care, and also we are also into diagnostics and pharmacies, which we have overseas. It's predominantly a tertiary care. And so that's our extensive Middle East presence. Just recently, we have entered Kuwait, and we have also entered the Kingdom of Jordan with the new Astor. That's the Middle East overview. We are also doing due diligence in Egypt. Before I came to Kochi 1 year back, I had the good privilege of spending 7 years in Cairo, and I ran the biggest health system in Egypt. The only CEO in the world who has managed a hospital in the middle of a revolution.